So welcome back. Now we'll continue on the topic of opioid abuse. So we were talking about the various opioid receptors that are found in various tissues in the body, mainly the brain and the spinal cord. And there are 4 main opioid receptors that are available, that are well characterized. Okay, so there might be other opioid receptors that we have not discovered yet. So, but these are the ones that are well characterized. They are more unknown about them. So we have the mu receptor, also known as the MOR3 or OP3 receptor, kappa receptor, and then we have the delta receptor, and also the NOP, the nociceptin orphanin FQ peptide receptor, also known as the ORL1. So the mu receptor, it's mainly found in the brainstem, in the medial thalamus, in the spinal cord, and also in the peripheral nervous system. So among the effects, the main effects of the mu receptor activation is supraspinal analgesia, respiratory depression. So it depresses the respiratory system. So for example, if your respiratory rate is normally 12, it maybe goes down to 8 or maybe 6 or 5. So that's respiratory depression. And then euphoria, elevated mood, sedation. One becomes sleepy and sedated. And reduced gastrointestinal motility. The gastrointestinal organs become less motile, and this is why we see constipation with opioids. And also physical dependence might develop. So this is the most important opioid receptor, the mu receptor. And then we have the kappa receptor that are found in the limbic and other diencephalic areas, also found in the brainstem and also the spinal cord. So we can see that both here we have the spinal cord, and also we have the brainstem here, and also the brainstem here. Okay, and so this is important again for analgesia, but for the kappa receptor it's mainly spinal analgesia, as opposed to the supraspinal analgesia, which is predominant in the activation of mu opioid receptor. And then also again we have sedation here, and just as we had sedation here. And then dyspnea, which is feeling of which is shortness of breath. And then we have again dependence. We have dysphoria instead of euphoria here. So we have an elevated mood here, but here we have rather a down mood. Then diuresis, and also again this is similar to the top one, respiratory depression. Okay. With regards to the delta receptor, it's not well studied, and it's believed to cause psychotomimetic and dysphoric effects. So psychotomimetic means it mimics a psychosis, okay, psychotic effects. So you might have, besides hallucinations, you also might have delusions. And then you have the nociceptin or orphanin FQ peptide receptor, the NOP, which are found in the central and peripheral nervous system. So the effects are also again, it's besides anti-nociception, it is also pro-nociception, okay, and also modulation of drug reward, and might play a role in learning, mood, anxiety, cough, and also Parkinsonism. So we'll probably see a lot more about this in the years to come as we unfold more mysteries related to the opioid receptors and its effects in the brain, etc. So this is a common diagram that was shown, a chart. You have an increasing dose, and then you have increasing CNS depression. So when you start giving opioids, so this is not the chart that is unique to opioids, but it's just showing the levels. So we have sedation here. So at a higher dose, so you might eventually see death if you overdose on opioids. Again, this is just a chart to show you where sedation is located on the chart of hypnosis. So hypnosis here, and further up it's coma and death. So when we talk about tolerance to opioids, so tolerance usually develops to the many effects of opioids, but it does not develop to meiosis. So meaning that if you start, for example, a patient on say 40 milligrams of methadone, okay, so after say, and at 40 milligrams you will see a constriction of the pupils. So the pupils becomes constricted to, for example, 3 millimeters. Okay, so after taking it for many weeks, and you have increased the dose, but still you can, with the same dose, you see the effect of meiosis. You still see constricted pupils with the same dose, so you didn't have to increase the dose in order to see meiosis. But you might have to increase the dose in order to see analgesia, for example, or in order to see euphoria, for example, and the other effects of the opioids. But for meiosis, usually tolerance does not develop to this effect of the opioid. As for physical dependence, it develops usually if the drug administration is regular and continuous, and it becomes clear only if the drug is stopped. Okay, as long as the drug is not stopped, if you keep giving the drug, you cannot see, it's not obvious to you that the patient has developed physical dependence. So you might give the patient methadone, for example, for days, weeks, months, and you are not sure whether the patient has developed dependence until you stop the drug, and then it becomes obvious to you and to the patient and to everyone. So the severity depends on the type of opioid that is used and the dose, obviously, and also the duration of chronic administration. So the longer you give the patient an opioid, so for example, if you give it for months or years as opposed to giving it for weeks or days, so it will become more severe. The physical dependence to opioids becomes more severe, or physical dependence to that particular opioid become more severe if you give it for a prolonged period of time. So this is a little bit on opioid abstinence syndrome. So we have grade 0, 1, 2, 3 for the opioid abstinence syndrome. So grade 0 is drug craving, and they develop anxiety and drug seeking behavior. This is grade 0. And with grade 1, you have people yawning, being sweaty, with running eyes and nose. So they'll be like crying and the nose is running, and they develop a restless kind of sleep if they are able to sleep. So that's grade 1. And then Grade 2 is dilated pupils, so the pupils become dilated. So you have good flash, twitching muscles, and hot and cold flashes, and you might see shivering. And for grade 3, you see insomnia, you have some low-grade fever, there is an increase in the pulse rate, so you might become tachycardic, increase in the respiratory rate, and you might see an increase in the blood pressure, restlessness, cramping of the abdominal muscles, and then nausea and vomiting, diarrhea, weakness, and also weight loss. So psychological dependence is severe. It does not end after drug withdrawal, and it continues long after the pain and discomfort of abstinence syndrome have stopped. So even after the pain and discomfort of abstinence syndrome is over, but you still develop the psychological dependence on the opioid that you've been taking for some time. So it will continue for many months. So, and a lot of addicts will relapse due to this. So the first opioid, morphine, this is a naturally occurring opioid alkaloid. Then we have diamorphine, also known as heroin, which is a more potent analgesic than morphine, so produces a more potent pain-killing effects than morphine. However, it has a much more euphoric effect also when compared to morphine. However, the good thing about heroin is it's less likely to cause nausea or constipation, which are seen when giving morphine. And that's why we see that when we give morphine, for example, for the treatment of acute chest pain in myocardial infarction, you tend to give another drug to counter the effects of nausea. Well, you might give metoclopramide, for example. So heroin can be given orally, can be taken intramuscularly, can be used intravenously, subcutaneously, or also by inhalation. Methadone is a synthetic opioid. As you have seen in the table that we've shown, it has a very long duration of action, about 24 hours. The usual dose is 30 to 80 milligrams per day. And it's not clear why it causes increased sweating when you take it. And it also, just as the other opioids, cause constipation. And besides that, it causes, you might see dry mouth, patient becomes lethargic, and also a reduction in the libido of the patient. Methadone, still used in some places, not used in others. So it's used as an analgesic in childbirth and also post-operatively. So in some places they are very comfortable with this drug and they know the effects. So they are still comfortable giving Methadone. So not sure whether it's going to over the years whether people are going to use less of Methadone, but so far people are still using Methadone in some places. Codeine, another alkaloid found in crude opium, is much less effective than morphine for analgesia, used for mild to moderate pain, and also to treat diarrhea and also cough.